ஓகே. போக்குவரத்து எங்கேயாச்சும் வரக்கூடாது. நீங்க நீங்க வீடியோ ஆஃப்ல தானே காட்டுச்சு இல்லையா? நீங்க எப்ப திருப்பி ஸ்டார்ட் பண்ணுங்க. மியூட்ல நீங்க ஒன் பிளஸ்
டன். சரி ப்ரோ, ஓகே. வருதா ப்ரோ? வருதா? ஆல் ஃபைன், டன். ப்ரோ டன்.
Child with parotitis.
நம்ம சாப்டர் பண்ணிடுறாங்க
Video off.
ஒரே ஆமா, இப்பதான் மத்தியானம். டிபார்ட்மெண்ட் ரிவ்யூவா? சரி சரி. ஆமா, இப்ப ஆக்சுவலா பார்த்தா இது வேற ஒரு மீட்டிங் எப்படின்னு தெரியல.
டெய்லி கட்டி வச்சிருவாங்க. அவர் காலவர ஆச்சு, அப்போ கறி அவர் சாப்பிட்டாரு. இவங்க ஊற்றி வைக்காம அப்படியே சாப்பாடான்னு கேக்குது புதுசு. அதுக்கு தெரியும் எப்பவுமே
அதெல்லாம் போதுமா இல்லாட்டி
சென்ட்ரல்
சிஸ்டர் என்ன சொல்லுது என்ன சர்வீஸ்
வருது.
whatever you call it, and high inflammatory markers, culture, sterile, infant with persistent fever spikes, irritability, I think. Yeah, thrombocytosis. Platelets were going up. The second platelet was 9.5 lakh. Now I don't know. Hemoglobin was 7. You know, we learned with 9.5 lakhs to 7 billion. We get 9.5 and not to 7.
Thank you, madam.
Share the follow-up of this child.
So carry home message for postgraduates. Any infant, high-grade fever crossing more than 1 week without any focus with inflammatory markers like ESR, CRP, and thrombocytosis with any organ involvement unless otherwise proved Kawasaki. So now parotitis 2.0 from KKCTH.
Next presenter will be Dr. Anirudh from KKCTH to present the case of recurrent parotitis and IgG4 related diseases.
Good afternoon to one and all present here. Thank you for giving. Hello. Good afternoon to one and all present here. I want to thank you for giving me this opportunity to present here in this case. My name is Dr. Anirudh, and I am presenting this presentation under the guidance of Dr. Dhanlakshmi from KKCTH. This is an infant. This is a 4-year-old male child who presented with OB with recurrent painful swelling of the parotid region, mostly unilateral, sometimes bilateral, since 1.5 years of age, once in every 2 months. He had pain and swelling which were incident in onset and persisted over 1 week. He was initially treated with oral antibiotics, with every episode recurring after 1 week. So since there were persistence of symptoms, he was brought here for further evaluation. In history, there was no history of dry eye, dry mouth, no abdominal pain or vomiting, no history of autoimmune diseases or any chronic illnesses in the family. He was immunized up to age under IAP schedule. On examination, he was afebrile, had bilateral painful parotid swelling, which were 3 × 3 centimeter, which was tender, firm in consistency with signs of inflammation, and bilateral parotid lymphadenopathy with largest measuring about 2 centimeters. The oral cavity was normal and the systemic examination was normal and all the vitals were normal. This diagnosis were chronic recurrent parotitis with the differential being Sjogren's, sarcoidosis, IgG4 related disease, juvenile recurrent parotitis, and chronic infective etiology. So approach to parotitis, I just want to say a brief word about it. So any infant with any children presenting with parotid swelling can be differentiated into two types: first episodes and recurrent episodes. In first episode, they can be differentiated into acute inflammation, chronic inflammation. Acute being viral or suppurative disease, and with chronic differences being HIV, granulomatous infections, chronic bacterial infections, and other causes which were previously discussed in the first presentation. And in the recurrent episodes, the treatable causes can be ruled out with the differentials being Sjogren's, sarcoidosis, IgG4 related disease, HIV infection, primary immunodeficiencies, and duct malformations or silolithiasis. And of all these, the juvenile recurrent parotitis is the diagnosis of exclusion. So initial investigations were done, which were within the normal limits. ESR was mildly elevated. HIV was done in view of primary immunodeficiency, and immunoglobulin profile were normal, except IgG was mildly elevated. And ultrasound next showing abnormal ecotexture of bilateral parotid glands with multiple tiny echogenic foci in the bilateral submandibular glands. So ANA was done, which was positive, and anti-Ro and anti-Law was done. And calcium and ionized calcium were normal. AC levels were normal. Optical examination was normal. Since IgG levels were high, we did IgG4 level was increased. So we considered the differential of IgG4 related disease. So due to suspicion of IgG4 related disease, we tend to look at IgG4 levels, which were usually more than 1.35 gram per deciliter. Even though it is a little high, which has high specificity, it has low sensitivity, and other diagnosis should be excluded if it is not high. And if it is high, then we can proceed with biopsy. The biopsy might be might show characteristic pathology such as lymphoplasmacytic infiltrates, storiform fibrosis, and obliterative phlebitis. And immunohistochemistry can show IgG4 related cells, which is more than 10. And if all these were present, then we can make a diagnosis of IgG4 related disease. If not, we have to look at other differentials. In histopathology for this child, we noted dense lymphoplasmacytic infiltrates exhibiting hyalination, and the occasional plasma cells were seen. And there was chloroform pattern of fibrosis, which is actually the cartwheel type of fibrosis noted between the normal glands. And histochemistry was showing around 5 IgG4 cells. Since we have done a focal biopsy, not an excision biopsy, we couldn't categorize this as a positive finding. So according to the diagnostic criteria, which was 20, the IgG4 related disease, this was the article where the sensitivity of the IgG4 concentration in the blood was shown as low sensitive and low specificity. But yet, we still follow the same criteria. According to this criteria, he had a clinical examination which showed a characteristic localized or diffuse swelling, and hematological examination was high. And histopathologically, he was having marked lymphocyte and plasmacyte infiltration. Since we could not do the complete biopsy, we could not achieve the fourth criteria. So overall clinical picture, the biopsy values and the lab values were suggestive of IgG4 related disease. So for this child, we treated him on hydroxychloroquine, and since there was recurrence of symptoms after 2 weeks, we started him on oral steroids, and we were planning to taper it over 6 weeks. After two weeks, we started him on steroids tapering agents, like we started him on azathioprine, and now the child is asymptomatic on tapering dose of steroids. So what is IgG4 related disease? A quick word. It is a newly recognized fibroinflammatory condition with several features such as tumor-factive lesion in multiple sites occurring over all parts of the body, and a characteristic histopathological appearance, often but not always elevated serum IgG4 concentrations. So clinical presentation can be from orbit, lacrimal gland, salivary gland, thyroid, liver, blood vessels, and retroperitoneal fibrosis, kidneys, and skin. So treatment options right now include prednisolone, azathioprine, mycophenolate mofetil, and rituximab. So these are the recent articles that were published where IgG4 related disease was presenting as parotitis. Thank you for giving me this opportunity.
How much does it cost, IgG4? And we had a series of around 3 cases of fibrosing mediastinitis presenting with tachypnea, SVC obstruction, inferior pulmonary vein obstruction. We didn't do any biopsy. We tried for 1 case. Histopathology is pending. Have you ever come across those kind of cases? Because we had a surge of cases of IgG.
Only IgG was high, so probable diagnosis of IgG4 related was considered. In fact, they say ultrasound package shows multiple hyperechogenic lesions itself is a classical marker of IgG4 disease. But so many differences, at least we should have IgG elevated with possible proceed with an IgG4 and biopsy.
So for postgraduates, what will be your carry home message from this case? Because these are all new things. We are moving into more and more immunological cases right now.
findings. If there is a multiple child hypoechogenic lesions in the submandibular gland, and the pediatric negative with infant ESR is silent, along with the IgG will be elevated. So indirect markers do ability. Globulin is high, we can assume IgG may also be high. So these are things which favors towards, like again, IgG this is of exclusion. So lumin will definitely dominant and sarcoidosis. So basic investigations like AA and anti-SSA role has to be done. And serum calcium AS levels has to be done to rule out Jawbone and the sarcoid. Then we'll think of probable IgG for it.
So even we had one case 2 years back.
HP, total sample can get the number of more than 10 cells per hypothesis. We are doing only fraction of only excision biopsy, only a fraction of the tissue we are taking. So the number is not very important. So even if you have 1 or 2 cells, I think IHC suggests IgG for positive cells, it concludes your diagnosis.
Okay. We had one case of a 10-year-old girl with perotitis, submandibular involvement also. When they did ultrasound, they told us the same thing, hypoechoic lesion. They told that hypoechoic lesions are suggestive of lymphocytic infiltration of any cause. For that case, ROLA turned out to be positive. So we thought that it is a case of Sjogren's presenting with recurrent perotitis rather than dry mouth, which was the initial stage, but turned out to be a case of HIV. Yeah, hypoechoic, the carry home message is hypoechoic lesions in gland is lymphocytic infiltration, right? From Apollo then. Shalom. Third.
I invite Dr. Renuka from Apollo Children's Hospital to present a case of severe acute community-acquired pneumonia, a diagnostic and therapeutic challenge.
Very good afternoon, one and all present here. I'm Renuka, DNB Pediatric resident from Apollo Children's Hospital. I thank my HOD Dr. J. Shamla for giving me this opportunity. Dr. Aisha, Pulmonology team, and Vidya ma'am, and Hematology department. This is about a 5-year-old female child who presented with a case of severe community-acquired pneumonia, which was a diagnostic and therapeutic challenge. A 5-year-old female child, when thriving, came with complaints of fever on and off, complaints of cough, breathlessness, and right-sided chest pain for the last 2 months. Outside hospital history, the child initially got admitted in Kolkata on 25th of January. With complaints of fever, cough, fast breathing since before the 20 days, and the child was managed with nebulizations. At the time of presentation, the X-ray showed a right-sided massive pleural effusion, for which intercostal drainage was done, and the pleural fluid was sent for culture, which showed streptococcus pneumoniae, and was started on IV ceftriaxone, vancomycin, and fluoxetine. So, due to the repeated desaturations and the distress, this child was taken up for CT chest on the day 9 of admission, which showed solidified empyema. So, which required thoracotomy and decortication. So, ICD was removed on the day 20 of admission. The child was discharged later. So after 3 days of discharge, child got readmitted due to the similar symptoms with respiratory distress. So due to persistent desaturation, child had to be started with HFNC support. And the respiratory viral panel showed the adeno, rhino, and enteroviral positivity. Similar desaturation persisted, so CT chest was repeated again, which showed a new consolidation on the left side, upper lobe, lower lobe, and the basal segment. So due to the repeated investigations of new consolidation and the infections, parents got anxious and got discharged against medical advice and came here for further management. So this is the first chest X-ray which was done on the day 1 of admission, which shows the right-sided obtundation of the right cardiophrenic angle with the bronchial wall thickening and the irregular heart borders. So this is the first CD chest which was done on the day 9 of admission, which shows a right-sided pleural effusion with the homogeneous opacity in middle. So this was a CT chest which was repeated again, which shows the left-sided new consolidation on the left upper lobe and the lower lobe. So past history, the child was a known case of Wheezer on budesonide inhaler since 2 years of age. And there was no significant work history was uneventful. A developmentally normal child, no significant family history, and the child was recognized up to age. At the time of presentation in our hospital, child was alert, active, and well-oriented. Child had normal heart rate. Respiratory rate was high, which was 48 per minute. Normal BP and saturation was around 94% in room air. And anthropometry, height was 105 centimeters, weight is 13.3 kg. Weight for age came around 3rd to 10th centile, height for age for 25th centile, and BMI was between 3rd and 5th centile. So systemic examination. Airway was clear, breathing, respiratory rate was, the child was tachypneic and had respiratory distress in the form of suprasternal and subcostal retractions. On auscultation, there was reduced air entry on the left infrascapular and intra-axillary areas, and saturation of 94% in room air. Circulation part was normal, no disability, and child was afebrile at the point of presentation. So with this history and examination, our DDs were recurrent pneumonia, tuberculosis due to the prolonged fever with recurrent consolidations, and a post-viral complication, secondary complicating bacterial infection or a fungal infection, or a primary immunodeficiency disorder. Cystic fibrosis, because child was a known case of Wheezer, had exacerbations before, which could have been an infection-triggered Wheeze, and to rule out any autoimmune or fungal etiology. So after presenting here, child had desaturation. So the child was started on O2 support, face mask with 2 liter O2, and was started on antibiotics, piperacillin and linezolid. In view of recurrent pneumonia, pulmonologist opinion was obtained and bronchoalveolar lavage was advised, and package was done. This was the initial blood investigation, which showed normal BC, no leukocytosis. Day 2 of admission. So normal. So the CRP done outside, that on the day 3 of admission outside was 257. On day 16 outside admission was 11. At the time of presentation here, on the day 1 of admission, it was 36.6. So the primary immunodeficiency package came out to be normal. And negative. B cell markers were normal. For ruling out NVT and THR assay was done, which were also negative. So then the BAL sample was tested, which came out to be positive for, which showed a few septate hyphae in the gram stain. And the BAL sample, galactomannan assay was done, which was 5.9. Anything over 1 is considered positive. And the BAL fungal culture showed positive fumigators. And the child was immediately started on injection voriconazole, 100 mg twice daily. So the child improved very well even after 2 days of starting injection voriconazole. So the child was discharged on day 6 of admission with oral voriconazole, 150 mg twice daily for 6 weeks. Child is on regular follow-up and is compliant to medications. A word about invasive pulmonary aspergillosis. The risk factors, invasive pulmonary aspergillosis is more common in immunocompromised people, in neutropenic cases, in post-chemotherapy and primary immunodeficiency. But this is also occurring in children post-viral states, particularly COVID, influenza and adenovirus. So this is the diagnostic criteria according to EURTC in 2019. So this includes four criteria: host, clinical, mycological, and the proof of invasion. Host is all the risk factors I've told. Clinical is the CT findings and the clinical parameters. Mycological is the positivity from the respiratory sample, either from the bowel or the serum. And a proof of invasion is the biopsy. We haven't done the biopsy, so it's a probable case of invasive pulmonary aspergillosis. So this is the spectrum. Lung damage, which proceeds to immune hyperactivity, can present as allergic bronchopulmonary aspergillosis, and immune dysfunction, any immunocompromised state, can present as invasive aspergillosis. So these are some of the articles. First one is an article about pediatric adenoviral pneumonia, which presented later as invasive pulmonary aspergillosis and post-viral aspergillosis. So take-home point is in case of persistent or recurrent pneumonia, we should always look beyond tuberculosis and any immunodeficiency state, and fungal etiology is also possible. Thank you.
Questions? Is it a commensal or aspergillus is ubiquitous?
And dramatic and it's not something that we will not consider, but physical response would yeah. Evidence of injection. Yeah.
So is it a comment, madam? Was there any dramatic response after starting origination?
அவர் ஏதோ வந்து பண்ணாரு இது என்னோட இதுல இருந்து வருது வாய்ஸ் இங்க இருந்து வருதா
with Martin's sternal retraction, within 2 days she became comfortable of oxygen and all kinds of stuff. So we are anyway following up this child. We plan to do a repeat seating, and so also thinking maybe
கேட்டா மாயா கோட்லயே வெயிட் பண்றாங்க. So she'll give me
So
a
carry home message. In this case will be any cases of persistent pneumonia. Usually when we find invasive aspergillosis, unless otherwise proved, our diagnosis will be phagocytic disorder such as a chronic granulomatous disease. 7 to 8 years back, we had 2 cases of oil instillation producing pneumonia. The child was not responding to any medications. We did ball turned out to be positive for aspergillus. Only after starting voriconazole, the child went well. So again, the carry home message is persistent pneumonia. You need to develop the habit of culturing the samples. So always you need to send the sample not only for bacterial culture, but also for fungal and other special stains. Thank you.
less common cause of generalized lymphadenopathy, a rare immune dysregulation syndrome in children. To present this case, I invite Dr. Rishabh from Sri Ramachandra Institute of Chennai.
Good afternoon all. I am Dr. Rishabh, DM Resident Pediatric Oncology from Srihar. Under the guidance of Dr. Dharani, I would be presenting a case of less common cause of generalized lymphadenopathy, a rare immune dysregulation syndrome in children. So this is a 4-year-old male child who was referred from Pondicherry to Srihar with the chief complaints of fever and abdominal pain for 2 weeks. Moving on to history of presenting illness, child had fever for 2 weeks with a maximum temperature of 100. No chills and rigors, no evening rise of temperature, and this started resolving with antibiotics. There was a predominant lower abdominal pain, and there was progressive abdominal distension. A child had constipation for 1 week and difficulty in passing urine with incomplete voiding and increased frequency of maturation for 1 week. There was no history of vomiting, bleeding manifestations, or any bony pain. There was no history of loss of weight or appetite. The child was treated at native place with oral antibiotics, but no improvement noted except for the fever settling. Past history, child had recurrent less severe infections requiring oral antibiotics in the last 6 months, but was never hospitalized. There was no significant family history. And these are the fever episodes of the child and from May 2023 till February 2024. And so on examination, child had pallor with significant lymphadenopathy of cervical, axillary, and inguinal region with largest of 3x4 centimeters. These are firm, non-tender mated nodes. Child was underweight and found to have moderate acute malnutrition. Hemodynamically, child was stable with an abdominal distension, and child was having a massive splenomegaly of 10 centimeters across the left, crossing the umbilicus below the left costal margin. So we proceeded with investigations. Child was evaluated with complete blood count initially and a peripheral smear, which showed bicytopenia of hemoglobin of 8.7 and a platelet of 94,000. Total count was 6,750, but a lymphocyte predominance of 82%. MCV, MCH were low. Reticulocyte count was 0.7. Hemolysis workup was negative, except for mild elevation of LDH. Serially done CBC showed low platelet count of falling of to up to 1,000. So this is the peripheral smear of the child showing microcytic hyperchromic anemia with thrombocytopenia with no atypical cells. So we with the above findings, we found that the child to have pallor, generalized lymphadenopathy, splenomegaly, and laboratory investigation showing bicytopenia. So common differentials considered were infections, leukemia, lymphoma. Child was worked up for infection and was on antibiotics, but we still had a high suspicion of malignancy. So we got the consent and we started proceeding with bone marrow aspirate and biopsy. Bone marrow aspirate showed a reactive marrow and showed a scanty marrow with no evidence of any blast cells. So we proceeded with PET-CT, which showed multiple bulky FDG avid lymph nodes with splenomegaly. So we proceeded with excision biopsy. This is the PET-CT report of the child, which shows a huge splenomegaly. So we proceeded with excision biopsy of the iliac node. The histopathological examination showed lymph node, which was replaced with closely packed follicles of varying size, and IHC was suggestive of reactive follicular hyperplasia. So we are totally confused. No idea where we will be. So we proceeded with autoimmune and immunodeficiency workup. Autoimmune workup and immunoglobulin profile were normal. We had done a DCT, which was positive, and vitamin B12, which was normal. So the clues here in this case were cytopenia, lymphadenopathy, splenomegaly, bone marrow inconclusive, lymph node biopsy was inconclusive malignancy, DCT was positive, autoimmune profile and immunoglobulin profile were normal. So we started thinking, rethinking, and then we considered autoimmune lymphoproliferative syndrome as a differential. So we proceeded with flow cytometry from peripheral blood, and we found this child having elevated double negative T cells. So this is the scatter plot, and this is showing CD3 negative and CD4 negative and CD8 negative T cells. So our diagnosis was probably ALPS with genetic sequencing was sent and it was awaited. Child was started on prednisolone 1 mg per kg per day and sirolimus 0.5 mg once a day. So the cytopenia improved and splenomegaly regressed in 10 days. So moving on to what is ALPS. ALPS is a disorder of immune dysregulation where there is a disruption of lymphocyte homeostasis, where there is a defective FAS-mediated cellular apoptosis. Basically, the cells which are supposed to get lysed are not getting lysed because of this mutation involving the FAS and FAS ligand. So, clinical features, usually they present with chronic, non-infective, non-malignant lymphoproliferation lasting for more than 6 months. They can present with autoimmune disease of, more than 80% patients have developed autoimmune disease, particularly cytopenia. They have possibilities of secondary malignancy, predominantly lymphomas. CVID is a close differential and considered as another end of spectrum of the disease. So the diagnostic criteria for ALPS, particularly two things are required. One is a required criteria, another is an accessory criteria. Required is chronic non-infectious non-malignant lymphadenopathy or splenomegaly for more than 6 months. Another is elevated double negative T cells, as we had in this case. The other accessory criteria primary is defective lymphocyte apoptosis or somatic or germline mutation. The secondary accessory criteria are labs such as elevated FAS ligand, elevated IL-10, elevated interleukin 18, or elevated B12 levels of more than 1,500. We had around 706. IHC consistent with ALPS, autoimmune cytopenias, and family history of non-infectious or non-malignant lymphoproliferation. A definitive diagnosis for ALPS is 2 required criteria and 1 primary accessory criteria. The probable diagnosis will be 2 required and plus 1 secondary accessory criteria. Gold standard for diagnosis is genetic sequencing. So treatment, lymphoproliferation rarely requires treatment, but if there is hypersplenism or cytopenia, you should start treatment with immunosuppressive agents. Steroids is useful for acute flares and sirolimus is a mainstay of management. Splenectomy is only indicated when the patient has severe clinical significant hypersplenism who does not respond to immunosuppression. So this is from another study where usually the child is started on prednisolone 1 mg per kg per day, and we follow up the child for 2 weeks. If there is a refractory cytopenia or the child is in need of therapy, we either go with mycophenolate mofetil or sirolimus, but we started with sirolimus with this child. And sirolimus is usually started at a dose of 3.5 mg per meter square daily. And you need to meet at a 5 to 15 nanogram per ml. The third line management will be vincristine, methotrexate, 6-MP, or sulfadoxine pyrimethamine. Usually they have a good prognosis, and ALPS usually improves with age, able to wean off the medications with time. The severity of ALPS varies from mild to severe within the same family. The following malignancies have been reported, particularly Burkitt and nodular lymphocyte predominant HL. So with this, I would like to conclude that any child presenting with cytopenia, lymphadenopathy, splenomegaly, first differential or important differential you need to consider is malignancy. And you need to rule out, though in this case it had turned to be out ALPS, it is important to rule out malignancy, and that's what we did. And I would like to thank Dr. Julius Kotzer, Professor and Head of Department of our Pediatric Hemato-Oncology at Srihar, Dr. Gayatri Ma'am, Professor of Pathology, Srihar, and Dr. Peter Prashant sir, who referred from Pondicherry, and the patient family for the trust and concept. Thank you.
Any questions from floor? Again, we are living in an era of immune dysregulation. So so is it a child toxic or non-toxic? Presentation was non-toxic. Non-toxic. Even we have around 5 cases of ALPS so far. Almost all of them are non-toxic because it is just lymphoproliferation. And the simple clue is whenever you get any case of bicytopenia or tricytopenia, invariably we will think in terms of bone marrow involvement. But one another clue before doing a bone marrow is to do a Coombs test, which indicates that there is an underlying autoimmunity. So, and he said the diagnostic clue will be double negative T cells. Even if double negative T cells are not available in any center, you can calculate CD4 and CD8, and you need to compare that value with the CD3 value. So when there is a gross disparity, we can presume that it is a case of increased double negative T cells, and we can treat accordingly. Again, we have 2 similar cases in the last 1 month. Thank you. So we request the participants to mute yourself, those who have joined through Zoom, both audio and video, please.
Good afternoon, everyone. Myself, Dr. Yuvraj, DNB postgraduate from Rainbow Hospital, here to present an interesting case about a refractory hyperammonemia in a neonate under the guidance of Dr. Ganesh, metabolic specialist, Rainbow Hospital. Patient summary. Birth history. A term male neonate born through LSCS with birth weight of 3.3 kg, cried immediately after birth with a second born to a third degree consanguineous parents, started breastfeeding soon after birth. But at 50 hours of life, the child developed seizures. Initially, it was a right focal seizure, then it became generalized and had an apnea for which the child was intubated. An initial ABG showed alkalosis and child found to have shock and referred to Rainbow Hospital for further management. At 70 hours of life, the child was admitted in Rainbow Hospital, found to have encephalopathy with weak peripheral pulses. Pupils was reactive and found to be in shock. Initial blood investigation shows normal CBC CRP, chest X-ray was normal, and liver function and renal function test was normal, and cultures was same. The glucose level was found to be normal, but ammonia was found to be abnormally high. It was around 2360 on admission. Lactate was 3.4 and ABG showed acidosis and ketones was negative. And then due to the very high ammonia level, proximal urea cycle disorder was considered and we started on treatment.
Hello.
During duty, it's difficult to see. When we started on treatment, the child was kept on nil per oral and started on dextrose, inodrops, sodium benzoate, L-arginine, carnitine, and peritoneal dialysis was
come out. Everything is coming to me.
After 4 hours of peritoneal dialysis, the ammonia level was found to be an increasing trend, and then continuous veno-venous diafiltration was initiated, and encephalopathy persisted. During that time, the plasma amino acid level, acyl carnitine, urine organic acid, and uric acid levels was also found to be normal. And then due to the shock was worsening despite CV-VENUS and inodrops, the CVS was stable and peritoneal dialysis was continued. At 120 hours of life, the ammonia level peaked around 5360. At day 5 of life, due to the very high ammonia level, carglumic acid, which is an NAG analog, was administered through NG tube. And then the ammonia level was in a decreasing trend, 2800 after 2 hours, followed by a rebound increase. And then VA ECMO was considered, but it was not started due to the persistent of coma more than 3 days and a very high ammonia level. At day 6 of life, despite all the measures, his ammonia level remained very high, and the poor prognosis was counseled with the parents, and the supports was withdrawn, and child passed away at 6th day of life due to shock and encephalopathy. This is an ammonia trend level, which showed a significant decrease in ammonia level with dialysis and carglumic acid. After a month, the molecular genetics showed a CPS1 enzyme deficiency. Approach to hyperammonemia. If there is an hyperammonemia, first we have to look at either metabolic acidosis is present or not. If there is a metabolic acidosis, then look for a ketosis. If it's a ketosis, it's more in terms of organic acidemias. If there is without ketosis, and it can be due to fatty acid oxidation defect. If there is a lactic acidosis present, then points more toward pyruvate metabolism disorder like mitochondrial respiratory chain disease. If there is a no metabolic acidosis, then look for ketosis or no ketosis. If there is a no ketosis, then it can be due to urea cycle disorder, or with ketosis can be due to maple syrup urine disease. Further, if you consider urea cycle disorder, further you can check for glutamine level. If it usually tends to be in a higher in case of urea cycle disorder, if the glutamine level is normal, then look for acyl carnitine level and urine or organic acid level. If it's high, can be due to organic acidemias or fatty acid oxidation defect. Citrulline high can be due to citrulline deficiency. If glutamine is high, then look for a citrulline level. This usually tends to be high in case of arginine 6-inate synthase deficiency or lyase deficiency. If citrulline is low, then look for urine orotic acid level, if it usually tends to be normal in proximal urea cycle disorder like N-acetyl glutamate synthase deficiency or cormyl phosphate synthase 1 deficiency. In urine orotic acid level tends to be increased in OTC or arginase deficiency or ornithine transferase deficiency. Treatment of hyperammonemia. Sodium benzoate, sodium phenyl acetate, L-arginine, except in case of arginase deficiency, and carnitine can be used. Peritoneal dialysis and hemodialysis can also be used. The carglumic acid, which is can be used in a case of a proximal urea cycle disorder, found to have a better effect in decreasing the serum ammonia level. And there is a refractory cases, VA ECMO can also be considered. Carglumic acid, it is a synthetic structural analog of N-acetyl glutamate, which is an allosteric activator of CPS1. It is usually available as a 200 mg tablet, should be mixed in water before administration, and it is can be stored in a room temperature. And the dose is around, initial doses around 100 to 250 milligram per kg per doses, and the maintenance dose is about 100 milligram per kg per day. In severe, moderate to severe renal impairment, dose needs to be adjusted, and side effects include vomiting, diarrhea, abdominal pain, and headache. And VA ECMO, there is no standard guidelines in usage of VA ECMO in case of hyperammonemia. But when compared to the peritoneal dialysis and CVH, the ECMO found to have a better ammonia clearance rate. Based upon the risk and benefits, VA ECMO should also be considered in severe hyperammonemia. Thank you.
Ganesh.
Initially, while before coming outside, it was alkalosis, but in our hospital first it was what do you expect? Due to respiratory component, the acidosis.
Baby was referred from a different hospital. So when the baby flew seizures, when the seizures persisted, they have done an ammonia in the referring hospital. At that time, it was high and the pH was about 7.5. Subsequently, we did not know for what reasons the baby went in for shock, had low BP, had low perfusion. So when the blood gas was repeated at our place, it was about 7.3 because the pH. Two different things in this patient is one, the urea cycle disorder presenting a severe form of acidosis and shock. We have not encountered that is number one. And second thing, this is basically to stress upon the importance of there are much more beyond the sodium benzoate and the peritoneal dialysis. So now carglumic acid is widely available. Even in centers who do the dialysis as well as where the ECMO facilities are there, you can just go ahead with the ECMO, which is very useful. The concept has changed. Giving to a baby is moved to giving a good neurological outcome. We had the option of ECMO, but we didn't try because by which time we came, the coma lasted for more than 3 days, and all the ammonia levels were more than 1,000. In fact, to prove that whether the dialysis is working, we have done ammonia levels from the dialysis fluid, it was consistently more than 2,000. So that means the production was so high. So everybody aims at removing the ammonia from the body by dialysis, but we here started by giving a tablet called carglumic acid, which is a facilitator for the enzyme itself. So even that did not work for the. There are literature reports saying that neonatal onset carbonyl phosphate synthase deficiency and NAX deficiencies are greater. That's the thing. And we have given a genetic counseling to the family. Probably in the next pregnancy, we can offer them genetic counseling. Carglu is available in US. We have to import it. It comes as 200 milligram tablet and a bottle contains 5 tablets. So each tablet costs about 12,500 rupees. So it comes as 5. So we have tablets. The family has given to us. Probably if anyone has coming with a hyperammonemia, if anybody sees, probably we can give them. So it can be given for all urea cycle disorders before we make the diagnosis. Once you make the diagnosis of a urea cycle disorder, only it is advisable for NAX deficiency in a long-term basis. Otherwise, any hyperammonemia we see in ICU, NICU, emergency room, we can just go ahead with carglumic acid. You need not wait for this 1,000, 2,000, even for 400, 500 also we can go ahead. Only limitation factors, it is not widely available. That's it.
Okay, thank you. So carry home for PGs. So any infant disproportionately sick, microbiological negativity, the first investigation of choice would be serum ammonia. Second one is your ammonia will trigger chemoreceptor trigger zone so that it can present with cyclical vomiting syndrome. Your ammonia can trigger respiratory center so that you can get respiratory alkalosis rather than acidosis. And the third point is, you all know it is a great mimicker of spastic diplegia, arginase deficiency. Thank you.
Let me now invite Dr. Meena Sri with a presentation unraveling a case of surgically curable focal epilepsy in a young child.
Good afternoon to one and all present here. I am Dr. Meena, first year pediatric postgraduate, here to present a case of surgically curable focal epilepsy in a young child guided by Dr. Ranjit sir, pediatric neurologist and epileptologist. So a 9-year-old female child presented from Kondattur to SRMC Koru. Chief complaints. Child presented with complaints of jerky movements of left upper limb lasting for 1 to 2 seconds for 4 years, increasing in frequency for the last 1 month, and episodes of unawareness in the form of blank stare, drooling of saliva, clenching of teeth with no loss of posture, lasting for 10 to 20 seconds. History of presenting illness. Child presented with focal seizures, complaints of jerky movements of left upper limb lasting for 1 to 2 seconds, 3 to 4 times per day, every day for the last 4 years, followed by a period of confusion, after which the child will immediately become normal. Episodes of unawareness lasting for 10 seconds, 2 to 3 times per day, in the form of blank stare, drooling of saliva, clenching of teeth with no loss of posture. This is a video of a child having an after episode of behavioral errors. We can see automatism of the upper limb, oral automatism. The child will not remember any of this after 10 to 20 seconds later. General examination was found to be normal. CNS examination, higher mental function and cranial system examination was normal. Motor system examination was also normal. Course in the hospital, the child was admitted with a provisional diagnosis of temporal lobe epilepsy under evaluation. Based on history and clinical examination, neuroimaging was planned. Baseline investigations done were within normal limits. We did an EEG, an MRI brain with contrast, a neuropsychological evaluation, and the child was then started on tablet oxcarbamazepine and clobazam. So neuropsychological assessment done was normal. There were no particular deficits in verbal memory, executive functioning, or cognitive impairment. Impression the child was found to be very high intellectually functioning. We did an EEG, which showed sharp spike and wave activity, suggestive of epileptiform activity in the right temporal lobe. We did an MRI brain, 3 Tesla, with the contrast, which showed a focal lesion in the right temporal lobe and a hippocampal and parahippocampal region. It was T2 hyperintense, suggesting calcification. So in view of temporal lobe epilepsy and a focal lesion on MRI, pre-surgical evaluation was initiated. What is pre-surgical evaluation? In view of focal lesions found on MRI, on basic investigations, we will plan further investigations like PET-CT and MRI scan. On PET-CT brain, we found mild diffuse hypometabolism seen in the medial half of the right temporal lobe and also entire of the hippocampus, suggesting a benign neoplastic lesion. So, summarizing the workup in a nutshell, we did an EEG and neuropsychological testing in the beginning, and then we did a functional MRI used to map language, motor functioning, and epileptic activity. We then did CT brain to localize the focus, and post-op we also did a CT brain. Following this, a multidisciplinary meet was held between pediatric medicine and neurosurgery team. So this is a case of temporal lobe epilepsy that is not yet drug resistant, with significant impairment, that is with electroclinico-radiologically concordant data, that is surgically amenable to resection. There was minimal functional deficit after surgery. Parents were counseled regarding this and informed consent was obtained. So the child was planned for neuronavigation and intra-op USG guided right temporal craniotomy with resection of the mesial temporal lobe under neuromonitoring. So in the surgical findings, we found a lesion of multiple consistencies, mostly in the hippocampal and parahippocampal region. On histopathology, we confirmed the presence of DNET tumor. This is a dysembryoblasthic neuroepithelial tumor. Post-surgery, we did a CT brain. There was a craniotomy defect in the right frontotemporal region, hypodense lesion suggesting post-op edema. This is a child at discharge. These videos were taken 2 months post-surgery. Even after removing part of the temporal lobe and hippocampus, the child has absolutely no deficit in memory, in function, and cognitive repair. This is some of the artwork done by the child 2 months after surgery. The final diagnosis will be right-sided long-term epilepsy-associated tumor and right temporal lobe epilepsy. So what are the benefits of temporal lobe lesionectomy? We will achieve not just control but cure of epilepsy. Anti-seizure medication can be slowly tapered off in future. So lesionectomy in a seizure-free, not yet drug-resistant child can prevent drug resistance and recurrence of seizures in the future. What are the risks? Since we are only operating on the non-dominant hemisphere, no major risk of language or memory loss is foreseen. There are obvious associated surgical risks. So we can conclude that benefits far outweigh the risks. There are 5 ways of temporal lobe epilepsy: aura, automatism, loss of awareness, post-ictal amnesia, and behavioral abnormality. So the term long-term epilepsy-associated tumor encompasses lesions identified in patients with long histories, often 2 years or more, of drug-resistant epilepsy. So characteristics and properties of LEATs that distinguish them from more conventional primary brain tumors are a young age of onset, with epilepsy as the only neurological symptom, slow growth, typically a neocortical localization, often a temporal lobe predominance. There are many studies on epilepsy surgery for non-drug resistant patients. Outcomes were significantly better when we have operated on non-drug resistant patients. So timing of surgery matters. Early surgery should be preferred to prevent likely drug resistance and to improve better prognosis. What is the take-home message? Epilepsy surgery is an option that provides cure in selected patients, even in those who are not yet drug resistant. So Ranjit sir has a new epilepsy monitoring unit that has been opened at SRMC. I would like to thank the Department of Neurosurgery, Unit 1, Dr. Lawrence, Department of Pathology, and Dr. Senta Christie, Department of Clinical Psychology.
It's not me that I have an epilepsy monitoring unit, it is SRMC. So I wanted to convey a few messages. Number one message for the pediatrician. The child presented with some jerky movements of the left upper lip lasting for a few seconds, and that was probably passed off as some kind of non-epileptic event. Sometimes like tick, or even the parent doesn't bring up. So any kind of abnormal event, probably a jerk in the awake state in daytime, you should make sure you are not dealing with seizure. The seizure was going on for 4 years, but that was more like a melancholic jerk. Only when the child developed behavioral arrest and drooling, things became very obvious. That's when they presented to us. That is point number one. Point number two, often the video which was shown is put on as absent seizure. Most of the emergencies across Tamil Nadu I have seen, they would put it as absent seizure. It is not absent seizure. This is current ILAE, focal seizure with impaired awareness. How do we differentiate? Last for a longer period, usually absence will not have drooling, and there will be automatism or nicely highlighted. Remember that 5 years of temporal eclipse. So you need to differentiate between these two, because absent seizure, you know the treatment of choices: and for A it is Oscar. Number 3, you don't have to have a patient who is having disturbing frequent daily seizures to be thought of for epilepsy surgery or referred for epilepsy surgery. Current school of thought is even before the patient develops drug resistance, if you feel the patient has a potential surgical option, you should probably think of other scenario because the benefit of epilepsy surgery far outweighs the risk involved. Because anti-seizure medications are not cured. நான் 2 வருஷம் மெடிசன் எடுத்துக்கிட்டேன் அதுக்கப்புறம் நீங்க EEG abnormal தான் இருக்குன்னு சொல்றீங்க patients will ask you. The medicine which you gave for 2 years is not to cure the epilepsy, it is only to control the seizure. The only way you can cure the epilepsy is epilepsy surgery. That doesn't mean you are advocating epilepsy surgery for all patients. It's only for selective patients where you have a potential lesion in one part of the brain, and even if you remove that part of the brain, there is no major functional deficit to the patient. If you have such kind of a patient, even if the patient is not resistant, he is a candidate will benefit from such. So this is for us because it's classic lesionectomy. Only one question I want to ask you: the patient has a right hippocampus removed and the right temporal lobe removed. And why is the patient absolutely normal, no deficit at all? The neuropsychologist revealed 110 IQ. That is very high function. Any explanation? Any pitches? You got the question. Hippocampus is the seat of memory. Because the patient is a right-handed patient and it is the non-dominant hemisphere, she highlighted. So you need to determine what would be the potential post of deficits also in that patient so that you can prognosticate advance. So we also do what is called as fMRI. fMRI is a test which can pick up which part of the brain gets activated when you perform a task. So you can do for writing, language, speech, or any task. So we typically perform for memory, language, and writing. The bottom line is anti-seizure medications are not curative. They are only anti-seizure, whereas epilepsy surgery is curative. That's all. Thank you very much. Yeah, this patient, ma'am, after starting Oxnard has been closed by some seizure free. So we still proceeded with them. So the tendency is if the patient is seizure free, continues it. The Chaltari kind of attitude, what we call it. It is not. You should kind of think, can I cure this epilepsy instead of achieving just control? That is what I want to break out. That's a very good question, ma'am. So if it is a dominant hemisphere, we do this kind of assessment. If there is a dysfunction of that, for example, if there is a hippocampal sclerosis, most often it's going to be a dysfunctional part of the brain. So we need to prognosticate. Sometimes if you remove that dysfunctional, you may not have additional deficit. So we prognosticate in that way. If the patient is high functioning, suppose the fMRI and all things are showing, if I remove that part of the brain which is going to have significant functional deficit, then we always do this kind of a risk versus balance analysis, explain the parent what are the risks and this thing. Even in Western countries, left-sided mesial temporal sclerosis in a child who is right-handed, sometimes they will not go for surgery. They may just give medicine or even VNS or other options. So that's a very important factor which we have to take. We were lucky it was on the right side hippocampus. Right. Focal seizure, first investigation of choice, neuroimaging. No doubt. Having said that, most common cause of seizure in children is not generalized as we think. It is actually focal. Because when you ask the parent is not a doctor, right? They will say generalized because they only see when it has become generalized. So it is actually the focal which is more common. So you have to ask the parent, start at the time of onset. Don't ask the parent when you saw it is the onset. If they see, I haven't seen the onset, I saw only when the child was convulsing, that means unknown onset. So if it is a focal seizure, the investigation of neuroimaging rather than EEG. If you are 100% convinced you are dealing with a generalized seizure, then you should go with EEG first. Having said that, in North India, every second case of seizure is neuropsychosis. So you should also deal with your commonality situation, where are you living. So several factors come into play.
A question from PRC, sir. Do we need to take child's consent for surgery?
Absolutely, sir. So about 12 years, it's called assent, and 18 years and above, obviously adult. So we do discuss that with the child, but we don't rely on the consent of the child. So we take the parental consent and inform, but we do tell the child what the procedure, whole procedure entails, what you go through. So it's a teamwork. And our psychologist also involved in preparing the child for the.
Thank you.
Thanks.
The bend did not melt. To present this interesting case, I invite Dr. Josna from Southern Railways Hospital.
Next. The reverse. Okay.
A very good afternoon to one and all. I'm Dr. Josna from Southern Railway Hospital. Today I will be presenting the bend that did not mend under the guidance of Dr. Nivedita Mitra Madam and Dr. Kavita. So a 22-month-old toddler was brought by the mother with a history of bowing of legs, which she noticed at 15 months of age when the child started walking. The child was born at 38 weeks of gestation with an uncomplicated pregnancy, second born of healthy non-consanguineous parents. Her birth weight was 3.2 kg, length was 48 centimeters, and head circumference was 34 centimeters. The perinatal period was unremarkable. On further history evaluation, the mother gave the history like the child was not gaining adequately compared to her peers. Age-appropriate milestones were attained. The dentition was attained at 13 months of age. There was no history of seizure, lethargy, irritability in the child. No history of jaundice, cataract, mental retardation, or alopecia. There was no positive family history, no history of any polyuria, vomiting, loss of appetite, constipation, or failure to thrive. On dietary history, there was a deficit of 200 kilocalories and protein deficit of 4 grams with a diet deficient in micronutrients. Family history, there was a stillborn birth of the first child at 8 months of gestation. The proband is a girl child and the third child is a male child, 5 months of age. On anthropometric evaluation, the weight was within 0 to -2 standard deviations. Length was -3 standard deviations, suggesting severe stunting. Upper segment, lower segment ratio was 1.7:1, suggesting disproportionate short stature. On head-to-toe examination, there was frontal and parietal bossing with ricketic rosary, widening of the wrist, genu varum, double malleoli of the ankle, disproportionate short stature. Systemic evaluation was within normal limits. And these are the features, the ricketic rosary, caput quadratum, double malleoli, and widening of the wrist joints. This was the initial presentation of the child. So with the case of disproportionate short stature with bowing of lower lids and diet deficient in calories and proteins, we thought of rickets and sort of nutritional rickets, and we went with the first line of investigations where CBC, LFT, RFT were within normal limits. And serum calcium was normal, serum phosphorus was decreased, alkaline phosphatase and PTH were elevated, and vitamin D was deficient. These are the serial X-rays which were done, and they showed cupping, swaying, and slaying. The child was initially treated as a nutritional rickets with vitamin D supplementation with 60,000 international units every fortnightly. And even after 12 weeks of treatment with the vitamin D, the child did not show any line of calcification on the subsequent X-rays, and the alkaline phosphatase was still high. So considering the other causes of rickets, we thought of refractory rickets on evaluated for non-nutritional causes. So in coming to the approach of the rickets, we did a blood gas analysis, which was normal. And the second line of investigations we did in that the stool for reducing substance and parasites was negative, and urine spot calcium was 0.2 milligrams per deciliter. Urine protein creatinine ratio was within normal, and urine spot pH was 6.2. Urine phosphate levels were 13 milligrams per deciliter, which is raised. So further ruling out other causes of non-nutritional rickets like hepatic causes, no hepatobiliary findings and the liver function test were normal. So we ruled out the hepatic causes. Second was no recurrent diarrhea history or oily stools or abdominal pain, anemia, hypoproteinemia. We ruled out the malabsorption causes. Third, there was no vomiting, lethargy, hypertension, anemia, edema, or features of any obstructive uropathy, and the blood urea nitrogen was normal. So we ruled out the chronic kidney causes. So I would like to explain about this chart. So we initially evaluated with 25 dihydroxy vitamin D and treated as nutritional rickets. But because there was no improvement with vitamin D, we went for further second line investigations and found there was rise PTH was raised and serum phosphate level was initially serum phosphate level was low. So we thought of hypophosphatemic rickets and we did the BBG and the BBG was there was no acidosis. So then we went for evaluating the TMP by GFR, which is tubular maximum phosphate by glomerular filtration rate, which was in this child, it came as less than 2.8, which is considered as low. And we further evaluated, considering the hypophosphatemic rickets, we further did the whole genome sequencing, which suggested X-linked dominant hypophosphatemic rickets. And we further evaluated with the FGF 23 levels, which was also right. And we did other systemic involvement like hearing assessment, ophthalmological examination, and USG abdomen, which came to be normal. And we did the mutation segregation in parents, which came negative. So after confirming the diagnosis of X-linked dominant hypophosphatemic rickets, we started the child on phosphate, oral neutral phosphates, which is 70 milligrams per kg per day in 4 divided doses, along with supplementation of calcitriol. After initiating the therapy for 1 year, the child showed improvement in increased bone mineralization. The rickety changes lesions were improving, but the genu-varium deformity persisted. So bilateral, lateral, distal femur and proximal tibial 8-plate application was done. To start the treatment at the time of the diagnosis is the dictum. So we have to initiate the phosphate with a dose of 20 milligrams per kg per day and gradually titrating it to a maximum daily dose of 80 milligrams per kg per day. Administer the phosphate in several doses, 4 to 6 times per day in the beginning of the therapy and decreasing the frequency to 3 to 4 times per day till the biochemical and clinical goals are achieved. And vitamin D analogs such alpha calcitriol 0.5 to 3 micrograms per kg per day up to 1 micrograms per kg per day should be initiated. On follow-up growth parameters, the child attained a weight of 13.6 kg, height was 80, upper segment still was a disproportionate short stature, head circumference was 57. This is the recent X-ray changes and the child presented like this, and this is the X-ray of the child post-operatively, and the child, this is the recent walk of the child. So coming to the pathophysiology of the X-linked hypophosphatemic rickets, there is a loss in the phosphate FEX gene leading to mutation in leads to increased FGF23, which causes the internalization of the renal phosphate at phosphate transporter. So that causes the decreased phosphate and phosphate wasting in the kidney, leading to it also leads to downregulation of 1-alpha hydroxylase, impairing the synthesis of 1,25 dihydroxy vitamin D and its degradation. Coming to the literature review that was published in the recent consensus guidelines in NEFROL in 2024. According to it, the genomic genetic study should be done in a patient with hypophosphatemia with elevated TRP and without hypercalciuria with a family history of X-linked hyperphosphatemia. We have to go for the genetic testing, even if there is no family history and the features are suggestive of X-linked hypophosphatemic case, we can go for the genetic analysis. And if there are no features and no family history, then you have to think of another line of other non-nutritional causes of rickets. So the recent treatment that was introduced was a Purosumab. It is an anti-FGF23 monoclonal antibody. It is recommended in pediatric age group 1 year and above with severe rickets with one of these manifestations with hyperparathyroidism, craniosynostosis, growth retardation of more than 2 standard deviations in stature. Dose is 0.8 to 2 milligrams per kg every 2 weeks, and in adults it is 1 milligram per kg with a maximum dose of 90 milligrams per dose. It should be given, it should be discontinued with the management when serum phosphate levels surpass the normal values. Follow-up should be done within 2 to 4 weeks, and the dose adjustment should not be done shorter than 4 weeks of period. Orthopedic, for any orthopedic surgical treatment, the disease should be under metabolic control for at least 1 year due to high risk of recurrence. Follow-up of these patients, it is categorized as 0 to 5, 5 years to puberty and puberty. So every 3 months, we have to evaluate the child on biochemical, orthopedical, hearing, ophthalmological assessment. For neurological fundus and MRI brain should also be done in any kind of headache. So follow-up is important in these children. So it is a multidisciplinary management in X-linked hypophosphatemic rickets. And why this case now? Considering the rarity of the disease, which is 1 in 20,000 prevalence, and timely diagnosis and management have great impact on the disease and alter the prognosis. Take-home message is most common cause of rickets are due to vitamin D deficiency, though it is not uncommon to come across vitamin D refractive rickets. It is prudent to pick up such cases and give proper treatment so that the child's growth is not stunted and the deformities are prevented. Multidisciplinary approach is required with genetic counseling. Thank you. It's done in CMC Vellore. Because FGF 23, it is not there, any rise levels are not there, only phosphate with phosphate they can recover. But if FGF 23 is involved, it causes the quantity. Cost, no ma'am, it's not a free cost. I don't know ma'am. So it's done in CMC Vellore. Actually, the child was on already on the vitamin D, ma'am. So it came in between.
But one question, it is a general thought that whenever you have rickets, in the absence of chronic renal failure, phosphorus will be invariably low. PTH is a biased fellow. He will respond to hypocalcemia. He won't respond to hypophosphatemia. So it is what we teach for the past 15 to 20 years. When you have hypophosphatemia in the presence of normal parathyroid hormone level, you need to suspect X-linked hypophosphatemic rickets. The only issue is parathyroid hormone level is high in your case. That's why, is there any explanation for that?
There is a secondary hyperparathyroidism.
That won't occur with the primary hypophosphatemia. Predominant lower limb.
Chubby cheeks are not always cute. This will be a presentation by Dr. Shalini Priya from Savita Medical.
Good afternoon to one and all present here. I'm Dr. Shalini Priya, second year postgraduate from Savita Medical College. I would like to thank my HOD, Dr. LRC ma'am, Dr. Syed sir, Dr. Joshua sir for giving me this opportunity. My title here for my case report is Chubby Cheeks Are Not Always Cute. We have a 11-month male child who came with complaints of fever for 1 day and the abnormal movement suggestive of seizures for 1 day. After the fever was high grade, intermittent, not associated with chills or rigors. The child had generalized seizures lasting for less than 10 seconds. After an episode of excessive crying, bluish discoloration of lips was noted during the second episode. No history of vomiting, loose stools, difficulty in urination or breathing difficulty was noted. The child was taken to government centers for vaccination and no prior history of consultations for any illness was there. Antenatally, the mother had history of anemia treated with iron sucrose. The baby was term, born by LSCS with birth date of 3.7 kgs. The postnatal period was uneventful, the child was exclusively breastfed and immunized up to age. While considering the developmental history, that, sorry. Yes. Developmentally, the child had attained milestones only up to 6 months of age, where the child was 11 months of age in all 4 domains. On examination, the child was febrile, alert, stridor was present, severe pallor was noted. The child was obese with stocky habitus. Craniosynostosis was seen. No dentition was seen in the child. Child had tachycardia, tachypnea, and the systemic examination revealed S1, S2 with gallop. Stridor was present with the chest was clear. Abdomen was soft with hepatosplenomegaly. The CNS examination was completely normal. The anthropometry revealed the weight was more than third standard deviation. The length was normal. Head circumference normal with arm circumference more than third standard deviation. Look how the chubby the child looked. 11 months and 15 kgs was the weight. The investigations revealed hemoglobin of 5.7 and serum calcium of 4.3. Further leading to the hemoglobin and peripheral smear revealed iron deficiency anemia and HPLC report was normal. Serum calcium was very low considering 4.3 and the magnesium levels revealed 1.5. Serum phosphate was high and alkaline phosphatase was high, which lead to us to check how the parathormone response was, which was high, which was 542 levels. Vitamin D was insufficient and also hypothyroidism was noted. TSH was 8.8. This was the X-ray of the child when presented. There was apparent cardiomegaly and hepatomegaly noted in the chest X-ray. The child presented with cardiac failure. The X-ray of the left wrist revealed short, broad metacarpals expressing the brachydactyly, bullet-shaped phalanges, and fraying of the distal metaphysis showing the vitamin D low vitamin D levels. To summarize, we have a child with obesity, development delay, seizures, severe anemia and deficiency with congestive cardiac failure, with laryngeal stridor and craniosynostosis. So all the investigations said that low levels of hemoglobin, calcium, magnesium, vitamin D and iron, whereas high levels of phosphorus, alkaline phosphatase and parathormone was seen. What or all can be the possibilities said? True hypoparathyroidism, pseudo-hypoparathyroidism and Albright hereditary osteodystrophy. Whereas in true hypothyroidism, we have low levels of PTH, so that is ruled out here. And since there is a hypocalcemia, hyperphosphatemia with high levels of parathormone, pseudo-hypoparathyroidism was considered as the diagnosis. And Albright hereditary osteodystrophy was the phenotype associated with pseudo-hypoparathyroidism. So how we manage the child with NIV support, PRBC transfusion, IV calcium correction and oral calcium correction, along with magnesium and calcitriol. Genetic analysis of the child was done, which revealed positive for GNAS associated pseudo-hypoparathyroidism. So, considering the diagnosis of pseudo-hypoparathyroidism, inherited disorder, we target all the resistance or unresponsive parathormone levels. So, instead of low hypoparathyroidism levels, be elevated levels in parathormone. So to summarize how parathormone regulates calcium and phosphorus levels in the body, the reveals how pseudo-hypoparathyroid type 1A, more commonly associated with GNAS mutation, along with PTH resistance, it also exhibits disrupted response to other hormones such as TSH, LH, FSH, GHRH, where primary hypothyroidism is also seen in this child. Individuals who acquire this allele from the paternal will have AHO and may not have PTH resistance, while acquiring from the mother, they'll have both AHO and resistance. So the child may also exhibit these features with age, such as features of hypocalcemia, including numbness, tingling around the mouth, painful muscle spasms, seizures, depression and dental problems where this child had no eruption of teeth by the 11 months and caused brittling of nails. And Albright hereditary osteodystrophy gives all the features where the child has covered most of the features highlighted in green. The child has excessive weight gain, round face, short neck, developmental delay, brachydactyly, and with age we'll be able to see the other features exhibiting in the child. Further evaluation, we have to see the calcium levels, phosphorus, parathormone, and vitamin D levels annually for this child, ECG for prolonged QT intervals, and height and growth monitoring and testing for growth hormone. And other endocrinopathies should also be ruled out to check by checking the TFT, LH, FSH levels. X-ray of upper and lower extremities should be seen to evaluate for brach. In this case of craniosynostosis, we have to plan for 3D reconstructive surgery. And do we treat with this oral to normalize calcium and normal phosphorus levels and to lower the PTH levels to minimize skeletal resorption? And symptomatic hypocalcemia should be treated with IV correction, and oral supplementation of calcium and calcitriol is needed. The complications such as brachydactyly will lead to difficulty with fine motor skills. There's increased risk of sleep apnea. Carpal tunnel syndrome is seen with AHO children, and early presentation of spinal stenosis is also observed. Chronic hypocalcemia and hypophosphatemia can lead to Parkinson's. So in mild forms of this disease, when treated appropriately with calcium and vitamin D, a normal life expectancy is seen. In severe expression of this AHO phenotype, in the presence of obesity, sleep apnea, and mental retardation can cause significant morbidity and mortality. And follow-up of this child is multidisciplinary in nature. Thank you.
You won't ask you any further questions.
To conclude the session, we have Dr. Umar Shankar from ICH Egmont to present a case of an 8-year-old child with progressive big tachypnea.
Good afternoon, everyone. Myself, Dr. Umar Shankar, fellow in critical care. I am presenting a case of a child with progressive respiratory distress and clinical course throughout our PICO and our evaluation and management. This was a clinical history. This was a 8-year-old female child, second born out of non-consanguineous marriage, brought with a complaint of fever, cough and cold for a past 2 days and breathlessness for a past 1 day. Child was a developmentally normal child and immunity up to age. Past history was insignificant and family history was insignificant. So for above that complaint, child was treated as viral pneumonia in the local nearby GH. They put the child on NRM, they started on IV antibiotics and antiviral. So their initial investigation showed hemoglobin of 11, total count of 16,000, and they took X-ray chest. X-ray chest showed right middle of pneumonia. Child had increase in the respiratory distress, and child was referred to ICH on day 9 of admission. On receiving in our PICO, our primary assessment was airway stable, breathing, child was tachypneic and with retractions with no added sound, and bilateral air entry is equal. Saturation was more than 90% with O2. Circulation component, child was hemodynamically stable and afebrile at the time of admission. So our primary assessment was child was in respiratory distress with hemodynamically stable child. So our initial management in PICO was we started a child on HFNC with 30 liter at FiO2 of 60%. We continued the IV antibiotics and IV antiviral. We nebulized the child. Our initial investigation showed of hemoglobin of 11, total count of 5,000, platelet of 2.4 lakh, and the other parameter of RFT, LFT, athlete was within the normal limit, and VBG showed respiratory alkalosis, and X-ray showed bronchopneumonia, and we got the CRP report was negative. So we evaluated the person, evaluated the cell. We evaluated for cardiac status, which was normal. We did the ultrasound test, which showed right middle and left lower of consultation, and we sent the viral swab report, which was negative. We did the TB workup, which was negative, and we did ICDC workup, which was negative. The course of the child in our PICO, initially the child we started on HFNC with high liter of 30 liter and FiO2 was 60%. And there was an apparently improvement in distress, so we tapered down the settings up to 25 liter and FiO2 was 50% for 2 to 3 days. Child has again deteriorated and increase in worsening of distress and requiring high flow up to 40 liter and FiO2 was 50% on HFNC. On day 5 of hospitalization, we electively intubated a child and put on mechanical ventilator. So it is a routine viral pneumonia that we were dealing with at that point. We didn't know. So we extended our further workup like we did CT test, showed diffuse ground glass opacity in bilateral lungs. We also did the COVID RT-PCR, which was negative, RA factor was negative, ESR was 38 at 1 hour. We also repeated echo, which was normal. Sepsis workup at the time of admission was negative. We did bronchoscopy, which showed thick, glossy, jelly-like mucous material in the tract. We could not able to do bond since the child had immediate desensitization at the time of bronchoscopy. This is the X-ray imaging of the child. The first X-ray showed the bilateral infiltrate, and the second X-ray showed the bilateral infiltrate with airlink like pneumomediastinum and pneumothorax, and CT chest showed bilateral ground glass opacity. And bronchoscopy imaging showed thick, glossy or jelly-like material in the tract. So this is the further course of the child in our PICO. Child had increase in bilateral infiltrate and airlink like pneumomediastinum and pneumothorax. So we proceeded with bilateral ICD. After discussing with the pulmo team, we started on IV IV pulse metilpred for 5 days for CT test showing the bilateral GGOs. On day 8 of hospitalization, child had no onset of fever spikes and thick ET secretions and CRP increasing and CRP increasing and ET aspirate showed clefairy growth. So based on the culture and sensitivity pattern, we hiked up the antibiotics. In spite of child was on ventilator, requiring high ventilator requirement, child was on refractory hyposmia. On day 8 of ventilation and day 12 of hospitalization, child went into shock and we started on inotrope. And the child could not be declared die on day 8 of ventilation and day 12 of hospitalization. So after getting consent from parents, we did postmortem lung biopsy, which shows linear course of fibrocollagenous tissue with edematous and fibrohemorrhagic area containing focally moderate lymphocytic infiltrate. Scan cell cluster noted with cell exhibiting mild atypia, nephromegaly, and hyperchromatic nuclei. So impression of the postmortem lung biopsy was lymphocytic infiltrate with rare cell exhibiting mild atypia. Not contributing for accurate categorization and further studies. They also added that if the clinical suspicion of malignancy is high, they asked us to repeat the sample, but we didn't have enough sample. So finally, the summary of this case was this was a 8-year-old female cell presented with a 4 week of illness with progressive respiratory distress. Child was AFib and CRP was negative, and the X-ray chest was bilateral infiltrate, and the CT was bilateral GGOs, and a bronchoscopy showed the glossy jelly-like material in the tract, and lung biopsy showed lymphocytic infiltrate diffuse cells exhibiting atypia. So, what is the final diagnosis of the cell? We didn't know. We didn't get any conclusive ideas about this case, whether it was a post-infective cyclase, post-infective viral pneumonia, post-infective bronchiolitis obliterans, whether it was a TB or HIV or COVID or ILD, or continuation disorder, or it was a malignancy, we didn't know. So carry home points from this case was if any cell present with respiratory distress not settled with our routine management, we extended our ideas and we should rule out other possible etiologies. So I thank my chief ma'am and thank the Parmo team. Thank you. Thank you.
First, we didn't have a diagnosis, but the problem was the problem of a fungal lupus. A thick, mucinous, jelly-like material which we have never seen.
We don't have diagnosis in this case.
Okay. Yeah.
தனியா கட்டல ஒண்ணு வாங்கினா ஒண்ணு வாங்கினா நெக்ஸ்ட் ஏதோ ஒரு ஆஃபர் கொடுக்குறாங்க. ஆமாங்க.
ஞாபகம் ஞாபகம் இல்ல பாப்பா ஞாபகம்
இது பண்ணாங்க.
ஞாபகம் இல்லையா
உங்க
ஞாபகம்
அம்மாவை நல்லா எடுத்து
நேற்று நீயா நானா
வேண்டாம்.
என்னென்ன
I told I was randomly telling her, you find some nice 5 girl games and 5 boy games.
எதுக்கு இந்த வேலை
I want them to be involved, Papa. Then she was like, நான் சொல்றேன் எடுக்க போறீங்க நீங்களே ஏற்கனவே டிசைட் பண்ணி வச்சிருப்பீங்க. அம்மா நான் டிசைட் பண்ணி வச்சேன் அட்லீஸ்ட் போறேன் அதுதான் பாருங்க என்ன
பாப்பா இந்த வேலை பண்ணாரு இன்வால்வ் ஆகணும் பாப்பா யாருமே
என்ன பாப்பா
கேட்கணும்
then she like நான் ரேண்டமா பாத்துக்கிட்டாண்டி தமிழ் பேர்ல எழுதிட்டு பாத்துக்கிட்டேன் உடனே அது சங்கி கட்டது